Good day, everyone. My name is Professor Margaret Kruk, and I am so pleased to be part of your Beyond Zero Summit. Thank you so much for inviting me. I'm here to talk about the emerging science on reducing maternal and newborn deaths. And this is a science that the country of Kenya is leading through leadership of the Ministry of Health, the First Lady, the Council of Governors, and some very brave pilot counties. I want to start by noting the huge improvement that Kenya has made in maternal and newborn health over many decades. In fact, maternal and newborn mortality have declined quite dramatically. And at the same time, access to healthcare services, and particularly delivery services for mothers, has improved. And yet, over the last several decades, Kenya, along with many neighboring countries, has faced a reduction in that improvement, has faced a stagnation in the mortality reduction. That means that we still have too many babies and moms dying of preventable deaths in health clinics, not just at home. And so the question is, what can be done? What can we do? What can you do to avert this remaining maternal and newborn mortality? Well, our group, together with the government and the First Lady's team, have looked closely at what the causes of death are and what the opportunities for improvement might be. And we find that in your country, as in many countries in the sub-Saharan African region, many mothers, in fact, up to 1/3, deliver at the primary care clinic, whereas another 40% or so deliver in hospitals, with the remainder delivering at home. When we compare that pattern to the pattern in high-income countries and in well-developed health systems, we see that all mothers in those countries deliver in high-quality hospitals rather than primary care clinics, and very, very few deliver at home. And so the question to ask is whether Kenya is ready and able to move deliveries from home and from primary care facilities all the way to the hospital. And this is where the emerging science begins. What we know is that although we have been reserving hospitals for high-risk women, any woman and any baby can become a high-risk patient, because complications of labor and delivery can arise without any warning, as most of you in the audience know. We also know that although we talk a lot about referral when complications arise at the first level clinic, the reality is very different. It's actually quite difficult to refer someone from a primary care clinic to a hospital in the time that it takes to save a life. When we look across your country, the question is, are there sufficient numbers of hospitals to be able to accommodate the women that need to be delivered? Well, that's a tough one to answer without looking within the county level. And so here we can see in Kakamega County, the county that is piloting service delivery redesign, that that county does in fact have a large investment already in hospitals and health center fours, such that they could be expanded to accommodate all of the deliveries in the county. We further see in Kakamega, but in many regions of Kenya, that many women live within 1 or maybe maximum 2 hours of a hospital. And with sufficient support, with transport, those women can reach the hospital without having to stop at a primary care clinic first. When we look at the options available in Kakamega, therefore, we see that there are sufficient numbers of hospitals to be able to deliver women. And we see that the knowledge of health providers is higher in hospitals than in primary care clinics. We also see when we talk to women and their partners and midwives that many midwives are very well aware that saving a life in a primary care clinic is extremely difficult, that she doesn't have the resources, the technology, and the team to assist in such a dramatic complication. And many of them would prefer to work in teams in the hospital setting. Bringing these factors together, it seemed to us feasible, and more importantly, it seemed to the government of Kakamega feasible to try to concentrate deliveries in health center fours that are upgraded and made to provide both humane and high quality care. Once we do this, improving primary care centers, so health centers 2 and 3, to provide antenatal care and postnatal care only and not delivery care, has been determined as the way to go. Many women and some women in the county will require additional supports with regards to access to the hospitals and may be requiring support at night in particular. We know that hospitals are not perfect, and this kind of transformation of delivery care from the first level, primary level, to the hospital level cannot happen overnight. Those hospitals and those staffs have to be upgraded, and they have to be retrained to provide the highest level of care. And yet we think that service delivery redesign, a focus on excellent care, humane care for every woman, for every delivery, every time, is the way forward in Kenya and Kakamega. I'll leave you today by just saying how impressed we are with the government of Kenya for taking on a new model of care, for testing a delivery model that is already adopted in much of the rest of the world, and for being brave enough to intentionally design the health system to benefit the lives of women and newborn. And we couldn't be more pleased to be with you today, even though remotely.